What's up, folks? Happy Thursday. Very excited for another case. There are a couple of interesting twists today. I think the first is that um, we have our fearless leader, Maddie, who is presenting a case. But before I pass the mic to say for her to say hi, I just want to thank the two people who are, or actually the three people today who are making this happen. Um, First is Julia, who has become a regular on these Thursday mornings and scribing. So, Julia, since last time, what's new?
Hello. Yeah, it's a very nice habit to do it on Thursday. For me, like it's a very nice time because it's afternoon and um a great like little gap to see the family here and learn something new. I've been actually in a period where I did some rotations in different hospitals to figure out where I would love to start my intern. So it's very exciting time for me. Yeah, and it's
Oh, wow.
it's a hard decision though.
I bet. I'm glad you're back seeing patients, so that sounds really fun. Awesome. Well, hey, you have I'm glad that you have a dilemma in front of you. It's way better than the alternative where you don't have any options. So, excited for you and excited to see where you end up going. You're accompanied, Julia, by two people who are doing teaching points. Somebody who has been older than VMR themselves, Yaz, but I'll first pass the mic to our one of our newest Academy members, Noreen. Noreen, please maybe introduce yourself to
Yeah,
the crew and tell us what's new.
absolutely. Hi, everyone. My name is Naurin, and yeah, volunteered to support me today since this is my first teaching point. I'm very excited to be here, and something new is that I recently made a basket. I'm trying to improve my basketball shot, and so this is after a couple of weeks of bruises and cuts and stuff like that. So I was very excited. Yeah. And it was in the middle of a game.
Whoa.
Yeah.
Sounds like you really earned that shot. Oh my God.
Yes, yes,
Oh.
it really felt good.
That's awesome. Yeah, you know what else? I think you're gonna get your second basket in about 50 minutes today. We're excited to see it live. And
Yeah,
I think
excited to
you're
be here.
I'm glad that your coach is in town too. Yaz, what's up?
Hey, I will definitely ask you later. What did you mean? I feel like a senior citizen.
Yeah, that's my new intro line for all the VMR legends, including you and
Oh my
Maddie, who
God.
are literally older than VMR itself. So, yes, Medicare, Medi-Cal, and all Medicare. I mean, yeah, it comes with a package at this point. Hey, I'm in the same bucket, yeah. So don't you worry. I'm not. This is not aimed at you. This is both of us.
I was thinking about saying it out loud, but you said it first. So
I did, and I'll bring another person in as Maddie, who is also older than VMR itself. Maddie, what's new with you?
Yeah, I was gonna say we're both older than VMR itself, everyone. But I'm just so happy to be here. As some of you know, I'm on my ICU rotation, so it's been a busy month. But I sometimes feel like I haven't missed out because every time I drive to the hospital, I'm listening to VMR, so I still like feel like I'm connected. But I'm so happy that I get to join live and present a case. And it's just so good to see you all.
Great to have you here, Maddie. I think, you're synonymous with CPS, just like Yaz, and so excited to whenever you're able to join live. And equally excited to be sharing the co-discussant seat with Mengyu, who I've known for a very, very long time, actually older than VMR for sure, but we collided forces in the world of CPS more recently than that. And Mengyu is one of the very, very rare people who isn't attending, who still has a passion to iron out the fundamentals and really prioritize clinical reasoning. Most of you all, whether or not you know it, statistically speaking, will probably gravitate away from this space as you find more nuanced areas of expertise, like how to cast somebody's left coronary artery, which I will never be able to do. But I'm really excited to share the space with you, Mengyu. I wonder if you have an update for people before we jump into Maddie's case.
No, I was just excited to see some faces that I met in at other circumstances, and I'm really excited because I've benefited so much from this community that I feel like I haven't been able to give back enough as much as I wish. And then, because CPSR is not only the source of learning, but also that I use that to take care of patients, teach residents, and really a source of constant inspiration and brings me ultimate joy in medicine. So I really kudos to you if you're here before residency and you're already joining or stumbled into the space, really would be excited to see you keep joining and become part of us.
I know, Mengyu, we're going to be out of a job soon with where these guys are at. So very, very excited to be unemployed and hopefully sitting here as an audience member in the near future. But Maddie, take it away, my friend.
All right. So as I was saying kind of before we opened the Zoom, I had been planning this other case that I saw a while ago, but this is actually a case that I saw yesterday. And then I just thought it was so filled with so much great learning. So I was excited to present it today. And I'm going to present it in a little bit of like a different format because I'm going to try to simulate exactly how I encountered the case. So if you can imagine, you are working in an ICU, in a medical ICU, and you get called about a rapid response on the medicine floor for a patient who just had a large volume of bright red blood from his rectum and is now hypotensive to 80s over 50s. So as we are kind of running to the medicine floor, I don't know anything else about this patient, but I will pause there and hear your thoughts.
Yeah, wow, what a hectic start. I think when I see a GI bleed, even if it comes from the lower GI tract, with this degree of hemodynamic instability, I would start thinking about upper GI bleed as a potential source. But before that, there are a lot of like management steps where you have to stabilize the patient by establishing 2 large bore IVs and reverse if there's any anticoagulation and start empirically PPI because of the concern of upper GI bleed. And then call GI, of course. And of course, I didn't mention like type and screen and I would start transfusion and even like thinking about massive transfusion protocol because patient can decompensate really quickly. And then after that, I would, potentially look into more history, but I think first step is to stabilize the patient. And also especially like important to clarify in terms of history, whether there's cirrhosis or history of like that or portal hypertension where you would have to start octreotide as well. Yeah, those are the things that came to my mind at this point.
I'm right there with you, Mengyu. I think these are situations in real life really create a tunnel vision reflex approach, and your reflex is so well honed and so valuable for people. And I think all that my role will be in this session is to explain that reflex to everybody, because I think you're not going to need me here at all. And I think what you're seeing in Mengyu's analysis is that unlike a patient who vomits blood, the differential diagnosis of vomiting blood is very simple. It has to come from the upper GI tract. But when it comes from below, you don't know where it originated. It could originate anywhere from the mouth, in fact, originate in the nose all the way down to the rectum. So, like when a patient brings up blood, the differential diagnosis of hematochezia includes both upper and lower GI bleeding. So you have to cast a very broad net. And I think that's going to be the diagnostic analysis. The therapeutic analysis is really all about stabilizing the patient hemodynamically by supporting them with transfusion and doing all the things that you need to do to make that happen, including putting in IVs, getting type and screen, getting patient consent. And I think you'll see that the 2 tools that are available to you in this moment are endoscopic visualization to address the bleeding and slow it down, to look from the inside. There's a very small role for imaging in this circumstance. And so I want you to really try to simplify this issue. Is diagnostically, this could be anywhere from mouth to rectum. From a therapeutic perspective, there's things that we put under the supportive category: blood transfusions, PPIs, octreotide. The ultimate definitive diagnostic and treatment modality is endoscopic visualization, and that's going to be key. But that can't be done in a patient who is too unstable, because if you were to put a patient in a vulnerable position of getting any procedure, if they're not stable, that can increase the risk of cardiovascular compromise. And so I think we're in the space where we're in the realm of supportive care, trying to be able to stabilize the patient enough that endoscopic visualization is the path. But There is a small role for CT angiography in patients who are hemodynamically tenuous and have lower GI bleeding. So that is one pathway we might end up taking. My only other big piece of advice is whenever you're engaging in a reflex response, to make sure you spend a moment understanding the center of gravity of the case. Because whenever your reflex response is triggered, you are making a fundamental assumption that whatever is triggering your reflex response is the center of gravity. And if you later learn that this patient has pulselessness in their left leg and has a really bad GI bleed, you might regret not zooming out. So I think the first thing I do in these circumstances is actually the opposite of what my reflex is, which is to make sure I look everywhere else before I go tunnel vision down into the hematochezia. I think that can be very, very easy to do. All right, Maddie, mic to you.
All right. Absolutely loved your discussion, both of you. All right, so to take you kind of where I was, so we are heading to the medicine floor, and when we arrive at the bedside, I immediately see this kind of line of chuck pads on the floor that make a line from the patient's bed to the bathroom that is covering up blood that has been on the floor. The patient is now sitting in bed, unresponsive, but has pulses. When we were called, the blood pressure was 80s over 50s, but when we look at the monitor, it's now 120s over 70s. His heart rate is 120s to 30s, and he's been placed on 2 liters of nasal cannula. And as you might imagine, there are many people in the room at the bedside, including the hospitalist who admitted him, an RN, and another RN who was working on obtaining access. So when we get in the room, we're looking at the patient and start asking kind of questions to the people in the room about what they know about this person. And what I learned from the hospitalist who admitted him is that this is a 62-year-old man with only known medical history of alcohol use disorder, with a history of withdrawal and hypertension. And this 62-year-old man presented to the emergency department 1 day prior with about 4 days of cough, shortness of breath, muscle aches, some vomiting and diarrhea. And he was found to be flu A positive. So he was basically admitted for alcohol withdrawal, and he had been getting Tamiflu for his flu A infection. And overall, he had been doing relatively well. He had been on the protocol for alcohol withdrawal, getting kind of lorazepam based on the protocol. And nothing kind of acutely besides that had been happening since for the 1 day that he was admitted. And then kind of when asked the nurse what happened, the nurse said that she heard grunting from the patient's room. And when she arrived to the patient's room, there was a long trail of blood that looked like bright blood from the patient's bed to the bathroom. And the patient was found in the bathroom to be pale, diaphoretic, unresponsive. So a rapid response was called. In terms of management, when I had gotten there, he had accidentally his IVs had fallen out when he was going to the bathroom. So the team was there placing 2 large bore IVs. 2 liters of LR was ordered. IV ceftriaxone, IV pantoprazole was ordered. And then labs, type and screen, cross match of 2 units of blood were ordered. And then he was transferred emergently to the NICU. And I'll pause there.
Yeah, Maddie, I love your presentation. It's like really vividly picture painting a picture of the patient in the room. Like it's amazing. Yeah. So I think what I gather from this very vivid picture is that the patient was probably like rushing to the bathroom and starting to vomit. So they're like maybe that's where you see the long trail of blood. And then while he vomited, and it sounds like this is like a quite abrupt start, and then there was maybe no clue beforehand because there was no IVs or something and those like that in place. So with this abrupt start, but I think the first important piece of information I gather is about the alcohol use history. And I remember there was an article about, does my patient with alcohol have cirrhosis? So like I found that to be helpful in terms of like how you find clues for whether this patient has cirrhosis. I think by default, I'll have to presume this patient has cirrhosis given the significant alcohol use history. But you can look for clues like any signs of pulmonary erythema or telangiectasia or gynecomastia, or on labs you can see if there's chronic thrombocytopenia or MCV elevated. Like those are certain clues to suggest this patient would have cirrhosis. Also, like of course, abdominal exam if there's any ascites or signs of portal hypertension. And then iron and other labs like synthetic like albumin, INR elevation are all other clues. So, but before that, like I would presume this patient has cirrhosis, and I would probably start octreotide at this time while we wait for further workup or information. And with another, I think, other than esophageal variceal bleed, which can happen like fast in a way that's like dramatic. Like in this patient, another consideration is if he's like starting to vomit and have blood coming out, could think of Mallory with tear or esophageal rupture or things like that. Especially if the vomiting makes me think more about upper GI bleed than lower, because the brightness of the blood makes you wonder if it's lower GI bleed, and which you can have like diverticular bleed that can be brisk. But it sounds like there's vomiting, right? I think that's my impression. Then I would still lean towards like upper GI bleed.
Oh, and
Yeah.
Mengyu, I'm sorry, just your thoughts are so brilliant. I just wanted to clarify, there was actually no blood from the mouth. It was all from the rectum.
Oh, right, yeah. Because otherwise you would have mentioned it. This long trail of blood coming from the stool, then I guess, like coming from like it's just leaking out the bottom. Yeah, then I would equally think about lower GI bleed as well. But I think the management would stay the same while we wait for workup. So I think like you would call GI to do a scope, and a colonoscopy can be a little tricky because like without prep, like the quality is a little limited. So like a CTA that, as Rabih mentioned earlier, to see if there's any, like where it's bleeding, I think would be helpful.
Absolutely superb reasoning, Mingyu, and I'm right there with you. I think again, I'll just take on the role of trying to trying to explain this to the medical student version of me who was very familiar with these circumstances, and I didn't do very well in them, to be honest with you. I was so cerebrally involved in my head that these acute situations were just overwhelming. And so I think that if I were in this position as a medical student watching Mingyu take phenomenal care of this patient, I think I would have two questions in my mind. The first is how come Maddie ordered blood transfusion for a patient whose hemoglobin we don't know yet? And I think understanding why her decision making was so spot on is really, really important. That would be the first question. And the second question I would have is, well, okay, we know the blood is coming out of the rectum. How do we know if it's an upper GI bleed or a lower GI bleed? And I'll just share reflections on those two questions. The first is that there are two indications for transfusion. The first is the patient has symptomatic anemia. And the second is that the patient has acute blood loss. Now, these two things seemingly overlap. But no matter what your cause of anemia, if your hemoglobin is less than 7, or if it's higher than 7 and less than a certain number, and you have prominent severe symptoms attributable to it, your patient gets a transfusion, and the transfusion can be dosed to try to get the patient above a hemoglobin of 7 based on their body weight. So symptomatic anemia means your hemoglobin has dropped to a point where it's causing problems, either because it's too low at 7 or it's low enough that you're really feeling poorly. And your hemoglobin is the only problem. There's another reason to give people blood, and that's not because you lost hemoglobin. It's because you're losing whole blood. So these two distinctions are best understood by visualizing what's happening in the patient's blood vessel. In transfusing somebody for symptomatic anemia is replenishing their hemoglobin alone. Everything else in their blood is nice and healthy. Transfusing somebody for acute blood loss is trying to fill up their now emptying blood vessels. And the idea being that unless the blood loss is stopped, the patient's ultimate destination will be to have no blood inside their body. And so you transfuse them no matter what their hemoglobin is. Why? Because they're losing hemoglobin, but their hemoglobin concentration is completely normal. That's because, unlike patients with slowly progressive anemia, who hemodilute and recruit water from the interstitium into the blood, lowering the hemoglobin, patients with acute blood loss just lose pure blood, and there is not enough time for interstitial water to come and further dilute the hemoglobin. So what is our threshold for treating somebody with symptomatic anemia, hemoglobin less than 7, or until symptoms reduce? What's our threshold? What do we treat to in a patient with acute blood loss? What we are trying to do is to give them enough blood such that they are hemodynamically not compromised. And you can see that that's a very nebulous goal. So we give people blood until their hemodynamics are not abnormal. And so you might see people giving blood until the heart rate normalizes or the blood pressure normalizes. And ultimately, when we stop the bleeding, we can stop giving blood. Two very different. So in the indication, if you are being scientific about your indication, the indication for transfusion is not anemia. The indication for transfusion is whole blood loss that is ongoing. And you need to replace that blood loss until you stop the bleeding. Very different circumstance, independent of the hemoglobin. The second question is hematochezia. How do we differentiate upper from lower? As Mengyu said, it's actually pretty difficult. So all I will do, just for the sake of time, is give you numbers. 15% of hematochezia turns out to be a GI bleed, upper GI bleed, excuse me. 85% of hematochezia is a lower GI bleed. So if there is 85% chance that it's a lower GI bleed, why would we even bother for the 15% that it's an upper GI bleed? It's so rare. That's because the 15% of upper GI bleed that is presenting as hematochezia is infinitely more morbid than the average lower GI bleed. Why? By definition, if an upper GI bleed is presenting as bright red blood from the rectum, it means that it is moving very, very, very quickly. Now, a lower GI bleed can also move very, very, very quickly, but most lower GI bleeds do not. So counterintuitively, the severity of all GI bleeds, all upper and lower GI bleeds in terms of morbidity and mortality is actually similar. But if you subselect upper GI bleeds presenting as hematochezia, you are subselecting a smaller subset of upper GI bleed that is infinitely more morbid. It turns out that pneumonias and UTIs in all comers are similar morbidity and mortality. But if you subselect UTI with sepsis, that's a much more serious issue than most respiratory infections. So here, the reason that we prioritize upper GI bleed in our thinking is not because it is more likely. It is because this subset of upper GI bleeds that is presenting with brisk blood means the patient is hemorrhaging fast in their upper GI tract. And that's why Mengyu is really thinking seriously about that, with addressing that with the octreotide, PPI, so on and so forth. All right. Well, maybe I wish I could hear those things as a medical student. These situations are very, very overwhelming. It's amazing to see, Maddie, your projected relative comfort, though I recognize in these moments there's probably not pure comfort, but I'll hand the mic back to you to keep telling us your very interesting story.
It was a team effort. I had a great senior and everyone was helping in this moment. So that was a really kind of wonderful part of it, the teamwork involved. All right, so at this point, we've kind of, the patient now has access on the floor and we're transferring him to the ICU. So as we're heading back to the ICU, I kind of tried looking in his chart to see if we could get more details about this patient. And as you said, was wanting to see if he had a history of cirrhosis. So when I kind of looked at his chart, he did not have many details in his chart. It seemed like it had been a while since he had been in contact with the healthcare system. From the admission H&P, I was able to see that had a history of alcohol use disorder, drinking about 2 pints daily, with his last drink about a day prior to admission. No history of cirrhosis documented. I looked in kind of the imaging tab to see if there was any abdominal imaging that kind of showed the liver and could identify cirrhosis. He had no abdominal imaging in the system. He had no prior EGDs, no prior colonoscopies, only past medical history of hypertension that I mentioned that he takes valsartan for, no other known medical history. And the only social history I was able to glean from the chart was that he was currently homeless, and no allergies listed in the chart. So we arrived to the ICU, and the kind of labs that we ordered from the rapid response returned. So his hemoglobin was 6.6, and looking back, the hemoglobin was 8.7 at the morning lab draw, and on admission the day prior it was 11. His white blood cell count was normal, it was 9, and his platelets were 50. The admission platelets were around like 60, 68. His basic metabolic panel was within normal limits. His lactate that was drawn at the rapid response was 5. The lactate was 1.4 on the AM draw and then 2.4 on admission. And then for his liver enzymes, he has an AST of 246, ALT of 77, a total bilirubin of 0.3, and an INR of 1.36. When we got him into the MICU, I was able to kind of examine him more. He was oriented to his name, to his location, but kind of intermittently responding. On quick physical exam, his extremities were warm and well perfused. And kind of the report that we had gotten from the rapid response was that it was kind of bright red blood on the floor from the bed to the bathroom. And I looked at kind of the pad underneath his bottom, and it was actually more dark blood that I saw. And I'll pause there.
Yeah, thank you, Maddie. I think the baseline hemoglobin being low first caught my attention. Oh, actually, the baseline is not that low, but it kind of gets lower over the course of. You said 8.7 was the day before, or is that that morning? Sorry, I forgot.
So it was 8.7 that morning.
Okay.
And then 11. And one thing I forgot to mention, the rest of the exam, he was not jaundiced, but he did have some abdominal distension.
Got it. Yeah. So it sounds like it's rather acute, although the baseline is not completely normal, 11. But I think but the bleeding, since the bleeding was noticed only that morning, I feel like it's probably taking a day to trickle down rather than all happened abruptly that morning, given the degree of anemia we're seeing despite the acuity of this happening, which I think that would make me think there's a process that's already starting over the course of a day. And I'm trying to think like what etiology would make that point. I think then I think lower GI bleed, I think being I also realized that's like more common in the setting of a hematochezia. So like some process in the GI tract. And again, and I'm seeing other labs suggesting a potential, suggesting actually signs of cirrhosis with the baseline thrombocytopenia. And then with the AST-ALT, if there's any clinical signs of like abdominal pain or, right upper quadrant pain or things like that, we could think about like the acute alcoholic hepatitis. But if there's no sign, I think that could be attributed to just like alcohol use related liver injury. Yeah, I think there's another thing I'm thinking, but yeah, I would start like building the differential for like lower GI bleed at this point, in addition to the upper GI bleed, which was stabilizing. At the most recent hectic upper GI bleed I've seen recently quite a few is that the Laffoy lesion, but that would be something I think. I feel like our GI doctor always do a EGD just to in the setting of a hectic lower GI bleed, but I think the lower GI bleed differentials, like including diverticular bleed, which tends to stop on its own or happens intermittently, and then angio dysplasia are still like possibilities. And then even I think in the setting of cirrhosis and portal hypertension. Oh, and by the way, so when Maddie mentioned there's like abdominal distension, like the thinking is that most likely in the setting of cirrhosis, I'm thinking about ascites, which again points toward like the chronic, like portal hypertension, which you can then expect to see some that not just in the esophagus, esophageal varices, but also in the rectum. So there could be like rectal dilated vessels that's bleeding, and could imagine that could cause this kind of rapid bleeding. So I think starting, and then I'm thinking about the workup, what the GI doctor might recommend. I think like you can still, I think still early colonoscopy, like within the first 24 to 48 hours, still recommended. If that cannot identify bleeding, then next step might be a CTA with potential IR procedure. Yeah, this is what I'm thinking. Although I'm keeping in mind like what other potential causes of abdominal distension. So I'm going a little bit back and forth, but those are the thoughts that came to mind.
I think Mengyu, unlike many cases where on VMR where the tempo of the presentation is more gentle and more indolent, we're not in the ICU. It's much easier to have a calm, logical next steps, but I think the morbidity of going the wrong way here often makes us actually think in very circular ways in real life. And in real life, if you're watching your attending or your senior resident, you often will not be able to get them to give you a cohesive chain of thinking. And I used to feel bad about that. And I still feel bad in the ER. This happens sometimes when there's too much going on where I'm like, trying to teach my resident or my student, but I'm unable to kind of put a cohesive linear narrative together. And I've ultimately realized that's just because it's not possible. And I think it would be too risky to get it wrong. And many times when we share hypotheses in VMR, if we're wrong, we're like, oh, cool, I got that wrong. So now I'm going to go the right way. But if you get this wrong here, you're going to be in big trouble. And so I'm right there with you. I'm open to both pathways being valid here. And I think that's why it's that reflex that you honed about hemodynamically supporting the patient is probably the most universal thing. And if you do that right, you'll be okay. You'll either pursue an upper GI bleed and you turn out right, great. If you turn out wrong, you'll pursue the lower GI bleed, or you go vice versa. And I think it really is an institution-based and education and an educated guess as to where this person is bleeding. And I'll just offer my 2 cents as an educated guess, but I know that I've been wrong many times and might be wrong again here today. I first just want to emphasize how unusual it is to see abdominal distension in a patient with significant alcohol use, because the marked cachexia and the associated nutritional deficiencies that come with that often leave a patient with the exact opposite of a distended belly, one that is cachectic. And so when you see a distended belly in a patient with alcohol use, the probability of cirrhosis really skyrockets, because the one thing that makes somebody with chronic nutritional deficiencies have a distended belly is fluid from ascites. And that, as Mengyu said, along with the thrombocytopenia, has me operating just like she did from the beginning, Mengyu. You're like, this is cirrhosis until proven otherwise. And unfortunately, it has not been proven otherwise. And the value of octreotide here to lower the portal pressure is through the roof. The efficacy of octreotide is very, very high. It's also a good point when you're thinking cirrhosis to realize that you have to not go crazy with transfusions. We talk a lot about complications of transfusions, and one of them is that you over-transfuse the patient and give them too much hemodynamic support. And by that, you increase their portal pressure and increase their bleeding risk. You do not want to under-support this patient's hemodynamics, but you do not want to give them too much blood and increase their portal pressure. And a hemoglobin target of 8 is a sweet spot between those two. So those would be what I would be thinking about transfusion. In terms of where this patient is bleeding from, I think the reason that people will start with an upper GI bleed evaluation is actually twofold. And Mengyu hit on this already. When you're bleeding, you bleed downwards. So if you stick a camera from below, your blood is gushing towards you, and there's all sorts of stuff in the way, like stool and whatnot, you can't see. But if you're bleeding downwards and you put a camera from above, much easier to see. So the yield of an EGD is much higher simply because of visibility. The other major advantage of an EGD is therapeutic efficacy. The vast majority of lower GI bleeds may have therapeutic efficacy with a colonoscopy. You can do all sorts of things, but unfortunately, in severe lower GI bleeding, the efficacy of a colonoscopy is restricted by visualization. And doing the same things to cauterize and clip is much, much, much harder. So EGD is often the default approach, primarily driven by morbidity, but also by visibility and ability to intervene. And that would be, I think, the default approach in most places. But I actually would say that I'm also investing diagnostically in upper GI bleed, and this is my reasoning. I think what Mengyu has picked up on is that the patient is having a slower GI bleed that was not hemodynamically significant and then became hemodynamically significant. And that, I think, helps us update our problem representation into hyperacute superimposed on acute GI bleed. And so the fact that this person was bleeding from his GI tract means that he was hiding some of that blood. It is much easier to hide some of that blood if it's bleeding from the upper GI tract, stays in the small intestine, and then comes out. How can I make this argument to you more clear? Imagine that this patient has a rectal varix and the rectum is bleeding. It would be impossible for a rectal bleed to not be apparent by causing a hemoglobin to go from 11 to 8.7. So if you are going to go from 11 to 8.7 without me noticing, you have to be far away from the rectum. Of course, you can be in the cecum, in the lower GI tract, but the probability of an hyperacute upon acute GI bleed suggests that the lesion is very far from the exit site. So for that reason, I would be more suspicious of an upper GI source in this patient because this patient's hiding blood from us. And the more room you give them in the intestine, the more plausibility they have to hide it. And so I would worry about that. And I think that counterintuitively, variceal bleed can certainly be hyperacute on acute. We all think that a varix just pops and goes. But you can actually have clot formation on a varix. And in fact, that's actually used as an endoscopic sign. It's called the whale sign, where they see evidence of recent bleeding on a varix that reinforces the notion of intermittent bleeding from variceal bleeding. So I would proceed with a tremendous amount of enthusiasm towards an endoscopy, both for practical purposes, upper endoscopy, but also because of this subtle hint that this might be hyperacute on acute bleeding. Mengyu, I'm curious how that hypothesis resonates with you. Any clarifications or counter arguments to it, or what's your take on it?
Yeah, I love how you're able to, I feel like you're able to more eloquently pick my mind, like describe like what was going through in my mind when I saw this hemoglobin trend, and then so I think it was very helpful also for me to more be able to like express like what was going through my mind, like the fact that it's the slower trend, the chronicity, the tempo actually points more towards like an upper, farther away from the rectum. And so so I think that was helpful to kind of share it and clarify here.
I'm loving this discussion, and it's so cool to see kind of the clues that you all are picking up on to see where the bleed might be. All right, so for the next set of information, so as you all were thinking, in the ICU, we started the patient on octreotide. And I called GI to let them know about this, and they planned for an EGD. In the MICU, we intubated the patient for airway protection prior to the EGD. And we, the blood had arrived, we started transfusing, we were getting labs frequently. And after receiving 1 unit of blood, the repeat hemoglobin was actually lower. It was 5.3 now. Ultimately, there was a lot going on in this moment, but the fellow made the decision to activate the massive transfusion protocol. And so ultimately, over the course of a few hours, the patient got a total of 5 units of packed red blood cells, 1 unit of FFP, and 1 unit of platelets. As I mentioned, the patient was intubated for airway protection, and an OG tube was placed that quickly drained around 300 cc's of dark blood. We were ordering like a thromboelastogram, a CBC, lactate, ionized calcium. Those were ordered Q4 hours. And I will pause there before kind of telling the results of the EGD.
Yeah, thanks, Maddie. Yeah, I remember like vividly from a case that I had in residency, also in the ICU, someone who had cirrhosis and came in with massive GI, GI bleed requiring massive transfusion. And there was not just the esophageal varices that we know about, but also like the vessels in the whole upper GI tract is kind of messed up. A lot of like kind of the liver bed was also bleeding, like was like bleeding a lot, just kind of diffusely. So I think the fact that the hemoglobin is lower is not totally surprising if it's like just from a delayed response. Maybe he hasn't got enough blood in yet. So I think massive transfusion protocol here will help. And then with massive transfusion, there are a lot of things we need to be cautious about, like you know, making sure give the right ratio of which is part of the massive transfusion protocol anyway, the ratio of blood products, and then replacing the calcium, because calcium will be low as you give the blood. But yeah, as you stabilize the patient, I think really EG, I'm curious what the EGD would show. I think I would be surprised if there's variceal bleed. I think that's probably like the leading hypothesis here, and perhaps like more diffuse bleeding in the GI tract potentially as part of the cirrhosis. I wonder if there's anything else, any other clues that would hint us towards some alternative thoughts here. Yeah, I'm curious if you have additional thoughts here, Rabih.
No, not at all. I am right there with you. I think that the thing that's on my mind is just what you said about the reinforcement of sort of like explaining fundamentally the massive transfusion protocol, and I completely agree with how you're thinking about that. I think the one question that folks might have is, what is the value of the orogastric or OG tube? That is a tube that's going from the patient's mouth into the stomach. And you might be sitting there thinking appropriately, why are Mengyu and Rabih talking so much about upper and lower GI? Please just put in an oral gastric tube and see if there's blood in the stomach. And if there's blood in the stomach, there's bleeding in the stomach. And if there's no blood in the stomach, there's no bleeding in the stomach. What are you guys hemming and hawing about? You know, this is probably what somebody who's going into a practical interventional field like surgery might say. All the internists scratching their chin. But the internists have a comeback to that argument. The negative predictive value of OG tube is very, very low. And it's actually reinforces the concept we've been talking about. Remember, where blood goes, it goes down. So if you put a tube in the stomach and you can't get blood up, it might mean that there's no blood in the stomach at all, but it might mean that the blood is going down. And so people have mixed opinions about the value of an OG or an NG tube to help you diagnose in a patient with hematochezia, whether they have upper or lower GI bleed, because one, the negative predictive value of an OG tube is low, meaning that if you don't get blood, that doesn't mean your patient isn't bleeding. Just 1 centimeter distal to where you put the tube in. The other reason is no single human being ever wants an OG or an NG tube. It's incredibly uncomfortable. And so if the patient's intubated and sedated, sure, use it as a diagnostic tool, but use it wisely. If the patient doesn't have bleeding from an OG tube, guess what you're going to do? An upper endoscopy. If the patient has an OG tube that shows blood, guess what you're going to do? An upper endoscopy. So all paths leads to an upper endoscopy. What is the value of an OG tube in this patient? It reduces the risk. By removing the fluid stuck in the stomach, it hypothetically reduces the risk of a massive aspiration event. 600 cc's of pure blood is going to come up at some point. And so you taking it out and putting it in a canister as opposed to the patient's lung is probably a good idea. But there's a hypothetical risk that when you do that, you actually make a varix bleed more. That risk hasn't really borne out in the data, but that's the calculus that you're doing. An OG or NG tube is not going to change your management, because if there's no blood, you're still going to do an EGD because of the negative predictive value. And if there is blood, you're going to do it with more vigor now. But what are you balancing? You're balancing discomfort to the patient. You're balancing the risk of worsening variceal bleeding by the trauma with the potential benefit of getting that blood out there so the patient doesn't aspirate it. So it's a complicated decision making. But I would say that in most non-intubated, non-sedated people, it's not worth causing the patient the discomfort of sticking something down there. But most patients who have this severity of bleeding need to be intubated either for airway protection or to facilitate an upper endoscopy. Alrighty, Maddie, back to you. What happened next?
All right. So what happened next is GI came and they did an EGD. And what it showed was severe esophagitis, but actually without varices. And in the stomach, they also saw diffuse gastritis. And they saw hematine, which in their note is kind of like altered blood or this coffee ground like material that was coating the entire stomach. And then in the duodenum, they saw 2 ulcers. There was one large ulcer that was oozing, and there was a significant adherent clot that kind of limited their ability to exactly measure the size. And so they injected that oozing ulcer with epinephrine, and they placed a clip on that duodenal ulcer. They also saw another ulcer, but that one was kind of clean based and not actively oozing. So this was kind of at the end of the day yesterday. We were trending the CBCs, and the hemoglobin actually increased to 10.3 after the massive transfusion protocol. The ionized calcium was low and we repleted it, and the lactate downtrended to 1 from 5. So that was kind of everything that happened up until the end of the night. So I left for the night, and GI, before I left, they kind of said, if the patient decompensates overnight or has worsening bleeding, call GI or call IR for kind of potential further intervention overnight. So I will pause there. I have like a little bit, I checked the chart this morning. There were some events that happened overnight that I can share, but we'll just pause there.
Oh, wow. I'm curious what turn of events that would happen, but prior to this, it all sounds classic. Like I realized like even before you started presenting this article, I realized I didn't really dive into like the differential for upper GI bleed. I think practically because in the real world, we just stabilize the patient, and because with PPI, this is like all you can do as a general internist, and then you leave the rest to the and then potentially prevent any esophageal variceal bleeding, and then you leave the rest of the scope to the GI doctor to identify whether it's a ulcer, or whether there's a peptic ulcer disease or esophagitis, which is also very common in the alcohol use patient, and one of the most common causes of upper GI bleed. So yeah, I think the findings are within expectation. And fortunately, this patient doesn't have a varices. But I wonder, like, I'm curious what kind of turn would happen overnight. I think from there we'll see what we're missing. Potential other source of bleeding, but sounds like he stabilized with the treatment that we're giving him, which makes me think the bleeding would hopefully had stopped.
Yeah, oh, no, go ahead, go ahead, Maddie, please.
No, go ahead. I was just going to share the kind of overnight, but go ahead.
Oh no, I was just going to emphasize that, like, I think it is an artificial exercise to go through the differential diagnosis of an upper GI bleed in a patient with risk for cirrhosis, because I think nobody thinks about anything except a varix until it happens. And the moment that scope passes the esophagus without a varix, and the moment that it looks and makes sure there's no isolated gastric varices as a result of a portal venous thrombosis or a splenic vein thrombosis, that's the time to start to think about what else could do it. But before that, I think I wouldn't do that at all in real life, because you're covering everything else with the PPI. But it is a humble reminder that even in patients with cirrhosis, peptic ulcer disease is actually the most common cause of an upper GI bleed in patients with cirrhosis. So it's just that we recognize it. It's just so common, but I think that you really have to broaden your horizons and then you can focus in on the other causes. So I was right there with you, Mengyu. I didn't think I was just Varix, and then everything else until proven otherwise. Yeah, sorry, Maddie. Go ahead, please.
No, I think just as you all were thinking, this whole time we were thinking that this was most concerned for like a brisk upper GI bleed. We're most concerned about varices given our concern for cirrhosis, though he didn't have a known history. And so that's where I kind of left it overnight. And then I checked the chart this morning, and it seems like the patient was still like quite unstable overnight and had pressor requirements. They ultimately got a CTA, abdomen and pelvis, to kind of look for the source of the GI bleed. And on that, it didn't show any evidence of active arterial or venous extravasation into the GI lumen. It just commented on like duodenal wall thickening and inflammation. And on the liver from that CTA, it identified like severe hepatic steatosis with patent portal veins. And given that the patient was having pressor requirements, looks like IR was consulted overnight. So IR actually did come, and they did a coil embolization of the gastroduodenal artery and the superior pancreaticoduodenal artery as well. But I checked this morning, and his hemoglobin is stable, his lactate remains down. So that's where we're at. And it's interesting is GI actually made the recommendation to stop octreotide, but continue ceftriaxone, given the concern for ceftriaxone, then he's still on the PPI. But that's everything. I absolutely loved your discussion, and I learned a lot from this case. It was an eventful day yesterday, and I thought you both discussed it so brilliantly.
Well, thank you, Maddie. Such a rich case with so many events happen, and ultimately, I'm glad you were able to stabilize the patient, help him, stop the bleeding. But to better understand, it sounds like there's an ongoing bleeding through the. So that had to require IR intervention for this ulcer. Do we assume that's the ulcer that's still bleeding, and to ultimately require IR to stop that?
Yeah, I think
bleeding.
I think the way I'm thinking of this case is that the patient had hemorrhagic shock from bleeding from this duodenal ulcer, and kind of the epinephrine and the clip helped to stabilize it, but was still unstable overnight. So that's why they needed to have IR come in and do embolization.
Yeah, wow. A really significant ulcer that I don't
I know.
often see that's excited too.
It was good learning for me, because I didn't, when someone has like such a brisk hemodynamically significant GI bleed, I was like, oh, varicose, but it was, I don't think I fully appreciated how bad ulcers can be, and how significant the bleeding from them can be.
Yeah, because in my impression, like most ulcers, you would like be able to heal with the start of the PPI drip, but apparently there are really deep ulcers like this. And then I think I'll put that on my differential for like really severe ongoing bleeding, in addition to the Lafoy lesion, which is another thing that you can't really stop with a PPI, that you have to require a scope or some intervention to stop.
Yeah, I mean, I think this is so you can dive deeper in this case and be like, well, wait, why does this patient have this ulceration in the first place? Do they have NSAIDs? Do they have H. pylori? And also, it's important to be like, wait, is the patient have an ulcer that is exposing a unique monster underneath? And that's the pathophysiology of a Dieulafoy's lesion, where you have a submucosal artery, an artery that takes an ectatic course into the submucosa, and then because of a gap, either because of an ulcer or something else, pops out and gushes. That's very, very different than the typical bleeding of an ulcer, where the ulcer erodes into the tissue beneath. And so I think that it's certainly very possible. Hard to tell. I don't know if IR has the. I don't think invasive angiography has the sensitivity to detect a Dieulafoy's lesion. So it's really, really good thought. But it goes to show you that even when you diagnose an ulcer, that's not an end diagnosis. You have to figure out, is it an NSAID related? Is it H. pylori related? Or most ominous of all, is it a malignant ulcer? And that's the role of the biopsies that GI do, that they and the role of repeat endoscopic evaluation, which is often done weeks later, to ensure that the ulcer is healed. So yeah, just there's so much rich learning here. I just wanted to thank you, Maddie, for your constant source of really practical bread and butter cases. Last time you shared with us a case of really bad coronary artery disease, and this time it's a case of GI bleed, the two most common reasons for hospitalization in the United States, cardiac issues and heart issues. So I think next time we'll probably expect a kidney case if
Yeah.
it's same.
Some
Based on,
AKI.
yeah, some acute tubular necrosis. I don't think we've ever diagnosed that on VMR. A good old case of ATN is I think is in order. Yeah, I really really appreciate it. I'm curious if you want to take a moment to emphasize some of the learning that you had in this case and ask Mengyu to do the same.
Yeah, and just to your point, I think it's a really great point about like, why does this patient have ulcers in the first place? And I think we still have some digging to do. We sent an H. pylori stool antigen, and it was a little bit challenging to get to history given how unstable he was. But with the GI team, we were asking him a few questions before he was intubated. He said he uses NSAIDs like on a weekly basis, and I don't know, I'm still learning, like, is that enough to cause this, or do you get ulcers from generally more frequent NSAID use? So I wasn't thinking that like weekly NSAID use would have led to this, but maybe it could have. And then in terms of what I learned, I think you all hit this point so well. When I heard like bright red blood per rectum, I was thinking, wow, like what, like lower GI bleed can come on like this quickly. But it was a great learning point that upper GI bleeds can manifest as just like blood from the rectum and not any like hematemesis. And so I think that was a really key point. And then also just kind of the practicalities of management comes before diagnosis in this case, and making sure they have access. They had like 2 large bore IVs. We put like a cordis in so that we could give large amounts of product there as well. And then just thinking about, especially if someone has risk factors for cirrhosis like PPI, octreotide, ceftriaxone, just kind of it's just interesting as well, kind of thinking through the pathophysiology of why you get hypocalcemia from kind of the citrate in the blood products binding up the calcium. So it was, I think I learned a lot about management of GI bleeds, but then also the key point that you have to consider upper GI bleeds, especially if it's upper GI bleeds with hematochezia.
Yeah, thank you, Maddie. My reflections at first, I was really amazed by how Maddie could present a bread butter case like this in such a breathtaking way, and so much rich learning points that you share with us. So thank you, Maddie. And then I think it's also really helpful for me, even though we see this commonly, but I think to really iron out some of the thought process and the data. For example, like for most lower hematochezia is like only 50% is upper GI bleed, but still we have to pursue that. And then the value of the OG tube, I think, is always something that I think so. So thank you, Rabih, for clarifying that teaching point here. And then also really going back to like understanding the base rate of the causes of upper GI bleed. And so I think it's very rich learning for me, even though it's a common case.
Yeah, likewise, and I really, really enjoyed discussing with you, Mengyu. It's always such a treat to be able to share the space with people at all levels. We have some of our team members who are preparing for intern year next year, and being able to discuss cases with them, and being able to do the same with you, somebody who's very seasoned, very well honed, and obviously takes excellent care of patients. And it was, yeah, really, really cool to share the space with you, and I'm excited to be able to do that more and more. But let's iron through the teaching points one more time. I'll hand the mic to Noreen and Yan.
Great case, everyone. I got to learn a lot. I know it's 10, so I'll try to be brief. Essentially, the main points we shouldn't forget is that even though it's a lower GI bleed with hypovolemia, we shouldn't rule out, we have to rule out an upper GI bleed because of the hematochezia. 15% is actually upper, and only 85. Majority of the hematochezia is going to be lower GI. But why should we bother about the 15%? Because in this case, the patient is hemorrhaging fast, and so the patient can worsen rapidly. And huge drops in hemoglobin, which is much more sneaky, means that the lesion is more likely to be further away from the site. And then we spoke about treatment. So we know large bore IV, impaired PPI, and especially if the patient has history of CLD with the alcoholic use, you have to think of using octreotide and also think of type and screening blood for a potential massive transfusion protocol. And also get consent and make sure you stabilize the patient. And in terms of using imaging, it's going to be the key will be with endoscopic visualization. And you can also consider getting a CT angio. Then we briefly spoke about blood transfusion indications, and we spoke about actual hemoglobin being low versus loss of the whole blood. So the indication will be symptomatic anemia or hemoglobin being less than 7, or the acute blood loss, which is ongoing. And then a good pearl was why not to use an OG tube. So the negative predictive value of OG tube is really low, and we would still have to do an EGD, and there's also an added risk of trauma as well. And another key important point to keep in mind is that bleeding is always in a downward direction, and so it's easier to do it from above. So this is why it's better to do an EGD instead of a colonoscopy. And then we also touched on whale sign on endoscopy, which is when a various clots. And then about the alcoholic history, we spoke about CLD signs like erythema, portal hypertension signs, gynecomastia, thrombocytopenia, MCV, AST/ALT ratio abnormality. And an important point was that the abdominal distension in alcoholic patient, who we would assess, like we would think that the patient is because he's alcoholic, he's cachexic and has nutritional deficiency. So if he has abdominal distension, we have to think of CLD and we have to be careful. And we have to be really especially careful when you try to manage transfusion of these patients, because we don't want to increase their total pressure and thereby their bleeding risk as well. So it's good to aim for a hemoglobin of 8, which is kind of a sweet spot. And we briefly touched on ulcer on scopy, what to think of. So we think of NSAID-related ulcer, H. pylori, malignant ulcer, and how it's important to repeat scopy if we are suspecting malignant ulcer. And yes, thank you. And thank you to Yaz for supporting me.
That was awesome. I would quote Elena and saying that this seems like you've done this thousands of times before. I couldn't agree more. That was absolutely awesome. Really, really captured all the salient features of this game. Well, big thanks to everybody involved. Thank you to Julia for scribing, to Mengyu for co-discussing, and Maddie for the awesome case, and a big shout out again to the dynamic duo of our teaching points. Hope you guys have a wonderful rest of your day.
Thank you.